Thank you for joining us this afternoon for our webinar on nutrition and diabetes, strategies registered dietitians use to support patients for better diabetes management. My name is Darlene Jenkins. I'm Senior Director of Programs at the National HCH for the Homeless Council. I will be your moderator for the webinar. With the support of I'm going to now show you our acknowledgement for our support. Our support for this webinar is from the Health Resources and Services Administration and the Bureau of Primary Health Care. This session is being recorded. It should last for 60 minutes. We do have 5 presenters on this webinar today, and we usually have save the end 10 to 15 minutes for Q&A, but what we will do is if we run out of time for the Q&A time, please still put it in the chat, and then we will answer questions as much time will allow, and then we will also answer them in a written form, and they will be placed on our website along with the archived webinar and slides 3 business days after this presentation. If you are having any technical issues, you may call the Council's office at 615-226-2292 for assistance. Again, if you're having any technical difficulties, please call the Council's office at 615-226-2292. So we're going to now introduce the faculty and get started because we do have a lot of information to provide to you today. Our first speaker is going to be Christina Watts, and Christina is from Clay City, Kentucky. Then our next speaker will be Kelsey Doll from Indianapolis, Indiana. Kimaya Joshi from Los Angeles, California will be our third speaker. Then our fourth speaker will be Elizabeth Murphy from Chicago, Illinois. And then our final speaker will be Laura Samnada from Atlanta, Georgia. So now I'm going to turn it over to Christina. Thank you. Oh, I'm sorry. Before I turn over to Christina, I do need to go over the goals of the webinar. Sorry, I'm getting ahead of myself. So we want to make sure that when you leave here, that we would have accomplished 3 things. One is to introduce you to a new resource, and that's going to be something that will be featured at the end of the webinar. The second thing we would like for you to take away from this webinar is that we want to emphasize the importance of medical nutrition therapy that is provided by registered dietitians. And then the third goal of this webinar is to share strategies registered dietitians serving in urban and rural health centers use to support patients experiencing homelessness with diabetes. So I mentioned the term medical nutrition therapy. It is the legal definition for nutritional counseling provided by a registered dietitian or a nutrition professional. And of course, in the resource that we will be sharing with you at the end, we make a distinction is made between a registered dietitian and a nutritionist. Anyone can call themselves a nutritionist, but a registered dietitian is licensed and credentialed to provide medical nutrition therapy. So it's very important that we focus on ensuring that people are getting education and nutritional counseling from a reputable source or a reputable person. But the medical nutrition therapy is very important. It's a professional, and they're an integral part of overall management of diabetes. Research has been found that A1Cs do improve when patients are referred for medical nutrition therapy, where a registered dietitian can follow them, can counsel them, and help them make the wise choices as far as food and nutrition based on their living conditions, cooking facilities, medication, and all the different facets that go into diabetes management. Now I believe I'm ready to ask one poll, and if you could please answer the poll and then we'll get into our presentation. Does your organization currently have a registered dietitian on staff that provides medical nutrition therapy? Yes, no, or unsure? Save one more minute. You can let us know if you have a registered dietitian on staff. Okay, great. Thank you so much. Thank you for the information. Okay. Next, I'm going to turn it over to Christina. And Christina, as I mentioned before, is from Clay City, Kentucky, and she is serving patients at the Foothills Health and Wellness Center. Christina?
Hi there, everyone. This is Christina Watts, and as she said, I am from Clay City, Kentucky. I work at a federally qualified health center, and we primarily serve patients in a very rural area. So in doing this project with this group, we've learned that rural can definitely look different than urban, and I will talk about that in just a second, what that might look different than what a population might be served in an urban area. But first, to start out, I wanted to talk about our clinic just for a second. Our clinic is recognized as a patient-centered medical home, and I'm not sure how many people know what that is. It was a new idea for me when I took this position. A patient-centered medical home is a health center that tries to serve on a care team, or it's patient-centered focused, it's comprehensive, and they try to do coordinated care. So we have a number of different care team members that serve the patients to try to have a holistic approach. So our care team consists of a doctor, a nurse practitioner, but along with primary care, we also offer behavioral health, substance abuse, nutrition counseling, and then we have care coordinators as well as case management. And all those different disciplines together, it works out well for the patient because we can treat the patient on much more than them coming in for sickness and being prescribed medicine. We try to tie them in with resources within our clinic as well as resources within the community to make sure that a lot of their needs are being met. So one thing that we do, we have care coordinators, and they're a very helpful tool for us because they'll step in with the patients in the room, and they'll do the social determinants of health to see if there are any needs that they can identify that we can actually provide with. And a lot of that focuses on food, nutrition, hunger, and then also with serving our patients with diabetes as well. So if they identify those needs, then they can make those referrals to myself, the dietitian, or to behavioral health, or they can also make referrals to some of our food banks that we have in the area. So that's one thing I wanted to talk to as far as trying to define the difference between urban and rural populations. Where we are located, we don't have any food banks within our county, so we have to try to find some other sources of food that we can give out or help provide or try to make our patients meet their need on a monthly basis. So we may refer them out for food banks. Our clinic ourselves, we can sometimes give out emergency food boxes if it's something that is needed right at that moment. And then another approach we have is we just have to get really creative trying to help our patients meet their nutritional needs. So that is where the dietitian can come in, as well as teaming up with care coordination. I'm going to move on to the next slide here. Okay. So when you're defining rural health care or rural homelessness, it can look a little different. You might have people that are doubled up in homes more often. You might have a lot of grandparents who are raising grandchildren. So sometimes what they financially can afford is going to have to be stretched for more people, so it becomes harder to make sure everyone is getting their nutritional needs met. Substandard housing, a lot of times where there aren't homeless shelters, you'll find a lot of people that are living in maybe some buildings or sheds or places that really aren't considered proper housing. And then transportation is also a major issue where you have further outlying areas. You have people that cannot access health care, they cannot access grocery stores, restaurants, much like a food desert, but that's something else that we also try to provide as transportation for our patients to get in. And this all goes along with how we, as a patient-centered medical home, how we then try to address those needs for our patients so we can actually provide the best care, especially when it comes to patients with diabetes, because there's a lot of issue with making sure they're getting their medications, making sure they're getting their nutrition met. So some things that we have tried as being a dietitian in the clinic, I'm going to go on to the next slide here. When it comes to some of my patients with lack of transportation, sometimes they may come for one appointment and we may not know if they're going to be able to come for the next. They may not have a phone that we can get a hold of them by, so if we can't get a hold of them, can't provide transportation, we're not sure if they're going to show up for their next appointment. I try to address the most important priorities when it comes to diabetes care. So, for example, I'll use the MyPlate model. I will give them a plastic sample of the plate just to explain what foods are going to increase their glucose. So I'll focus on carbohydrates and making sure that the patient understands what a carbohydrate is and that they can identify which foods are going to cause that blood glucose to raise. I also talk about portion control, but it's very important to try to ask open-ended questions. That way you can identify what their knowledge base is to start instead of trying to jump in and just give a bunch of information. You want to try to be as effective as you possibly can in the limited time that you have with them. So usually within that first assessment piece, I try to assess their knowledge base, focus on the simple carbohydrates, maybe portion control, and then if they come back at a later time, then I'll try to get into a deeper explanation of other health that might be affected, like cutting out sodium and focusing on healthy fats and that stuff at a later date, but trying to get those basics covered within the first appointment. Also, some things that we have done, you might have to try different approaches, especially if you don't have any food sources. So this last summer, we tried to incorporate a veggie voucher program to give some vouchers to be utilized at the farmers market. Along with that, we also tried to provide transportation for patients that didn't have it so they could be successful in the program. That's something we're going to analyze and see if we're going to try again. But it's just important to try different things because everybody's needs are different. So the individualized care is very important when you're looking at each patient to know what's going to be more effective for them. And then as well as working with the team approach, trying to find community resources within your clinic and outside, just having those partnerships so you know who you can refer to as well as who can refer to you. Being a rural area, we have very limited access to dietitians, so it's very important to try to put yourself out there so people can refer to your clinic if there's any nutrition needs needed. So with that, I'm going to pass on to Kelsey.
Thanks, Elizabeth. Or Christina, sorry. While I am kind of giving you a brief introduction of what I do as far as work over here in Indianapolis, I'd like everyone to take a second to answer our next poll question. So do you or the facility you're working at currently utilize that coordinated care that Christina was talking about that encompasses both behavioral and physical health? So here in Indianapolis, I work at two of the clinics in the Ashkenazi health system, and one of those clinics is located inside of a day shelter. And so over at that clinic, I primarily work with clients who are experiencing homelessness. And alongside with that, a lot of the time they will also be experiencing a mental illness or some kind of substance abuse struggle. Thank you for completing the poll. I appreciate that. So along with recognizing the importance of both behavioral and physical health. Our clinic has kind of combined that healthcare to address both of those in one place, similar to what Christina's doing. We have social workers, a psychiatrist, therapists, nurses designated specifically to work with the behavioral health side. And then on top of that, we also have a coordination with an outreach team, which is made up of, I think, upwards of 10 different organizations throughout our community that encompasses different areas in the city. So there's a police force team, there's a veterinary team, there's like a younger than 20 working with that population team, and we all kind of work together to go out into the community on designated days and check in with these folks kind of where they're at. So we'll go out to the different homeless camps or the shelters and kind of just see what their needs are, where they could get help if they need it, and kind of make sure they know the different resources that are available out in our community. The other big benefit of having both the behavioral health and the physical health all in one place is, like Christina said, it helps make like a one-stop shop for the client, and it can also help ensure that all of their needs are being addressed. So a lot of the time I'll be working with the case managers or the therapists on coordinating how their mental health is impacting their nutritional needs. So I have on more than one occasion had social workers help my clients like go to the grocery store, help them find healthier options on lists I've provided, work with them on budgeting, helping folks who might have like disordered eating patterns kind of regulate those a little bit better. And then along with that, we have a nursing staff that helps kind of manage medications if needed, and I'm going to talk about that here in a minute. But the psychiatrists have also been able to kind of refer clients as needed because unfortunately a lot of the times with some of the medications that are used, you can see an increase in insulin resistance or weight gain, which we can kind of help prevent or at least control to some extent if we help get those clients in to see myself or the doctors a little bit earlier. So that being said, medication compliance is a big part of diabetes management, as all of us know. And when you add homelessness into that equation, it can get a little bit funky. So, of course, the number one thing is always to continue trying to educate your client on what their medications are, why they're helpful, how often they need to be taking them, helping them understand how to use their medication, whether that's testing their blood sugar, using their insulin pens correctly. All that information is extremely useful and extremely beneficial to keep revisiting because I've experienced when stress can increase from like your camp being closed or you aren't able to find food properly, the medication side kind of falls to the wayside. So continuing to try to bring that back to the front and the focus to help maintain good blood sugar control. We have also kind of partnered with some of the pharmacists within our health system, and they have kind of opened the door to different medications that might be useful, especially in folks who are staying at shelters and don't have the ability to like store insulin. So sometimes we can help them get introduced to the 1-week injectables or like a slower digesting medication that doesn't cause as many side effects, that kind of stuff. And that's been very beneficial for our clinic as well. We also have started to offer medication boxes for some of our more fragile diabetics. Excuse me, guys. And we don't have very many clients that utilize this, but we have given them the opportunity to pick up their medications every 2 weeks, and so that allows them to not, excuse me, to not have to carry their pills with them to the shelter, which can reduce some of that stress that they can sometimes experience. We also talk about the importance of taking medicine either with or without food, because that can impact how effectively it works in the body. So I think pretty much everyone, behavioral health-wise and physical health-wise, tries to talk to the patient about that as far as their medications are concerned. The last thing that I kind of wanted to touch on was different programming that we have had success with over at our clinic. We have introduced a couple different programs over the past year that have been pretty helpful with some of the clients. One of them was a cooking class that utilized strictly a charcoal grill, because a lot of our clients will have access to either a fire pit or a grill kind of setup at their camps. I am so sorry. And we had a lot of participants really appreciate that, breaking it down and kind of understanding what resources they had available for them. So I would recommend anyone who's looking into starting like a nutrition-focused course for this population to try to take a look at what resources might be available. They might need very limited cooking, things that are just like ready to heat or ready to eat, require no cooking or no refrigeration, that kind of thing. But there are ideas out there, and you don't necessarily need to reinvent the wheel. Along with this class, we offered gift cards for our local grocery store, and I made sure that any ingredient that was in the recipe would be available at either the the farmers markets or in the food pantries. And I tried to really limit the amount of refrigerated food items to limit like food safety concerns on their end. I also had a lot of clients state that they would be more than willing to come and learn about different exercise options or healthy shopping. So those could also be ideas down the road if anyone was interested in nutrition or exercise programming for this population as well. But once again, kind of thinking about what resources are available to those clients and where their kind of barriers might be. The other thing to always allow with this population would be a flexibility. So with classes, weather can play a part, whether it's hot, cold, rainy. You might have less clients or more clients show up. In the situation that I showed on the picture down below, we actually couldn't get our girl to start because the wind was blowing too high. So I brought the class inside and we used the microwave. And I know that a lot of our clients won't have access to a microwave, but I wanted them to be able to see that it could be done and kind of have the final product tasted so they could see that a healthier version of an item doesn't necessarily taste that different than a normal item would be. So in this scenario, we made chickpea pasta with sauce and vegetable, and we kind of emphasized the portion of it for those who are working on blood sugar. So these are a lot of the tools and resources that iClinic has used over the past year, and I've learned a lot from the other ladies on the call. So at this point, I'm going to turn it over to Kimaya.
Hi everyone, my name is Kimaya. I'm a dietitian employed at the Veterans Administration Hospital in Greater Los Angeles. I cover many different clinics here, but the one I'll be focusing on today is our homeless-specific primary care team, also known as HPAC. Unstable housing is pretty high in the veteran population as compared to the civilian population, especially here in LA. And so in general, if you do encounter a veteran who's homeless, if it's able, please encourage them to visit their local VA hospital to get enrolled. This year, the VA has identified tackling homelessness as a focal point. Okay, so one of the major things I encounter with many of my patients is feelings of hopelessness regarding their diagnosis of diabetes. They tell me that diabetes is something they can't control given their lack of control regarding their food. Many of them live on the street or are temporarily in shelters or rely on food banks or pantries for meals, and they feel frustrated when they're told to eat better or differently because they want to. They just don't know how they can given their living situation. So my first point here is to break that misconception that homelessness automatically means a poor diet and therefore poor glycemic management. What I try to show them during my appointment is what they can control. So I do this through the use of motivational interviewing. I see from that poll at the beginning that there's many dietitians here. So it's likely that you're already using motivational interviewing techniques during your appointment, and I encourage you to keep doing so. For those of you who don't know what it is, it's a counseling approach where you solicit change from the client or patient rather than telling them what to do. And this kind of is similar to what Christina was saying earlier with the focus on open-ended questions. So an example is asking, how does high blood sugar affect your body? How might it be harmful? And seeing what their response is, versus telling them, oh, your high blood sugars can lead to kidney damage, infection, cardiovascular disease, coma, etc. Another example is asking, do you think that dietary patterns have any effect on your blood sugars? You might hear a wide variety of responses there, but if they say yes, you could ask, what do you think you could do differently? And for the most part, they have some pretty good ideas already. They just need a little bit of guidance on how to go at it. And this would be a more effective approach than saying, stop drinking soda, or no more cookies, eat more vegetables, things like that. I know these examples are kind of drastic, but it's just to show how a change in approach can solicit more client involvement and commitment to their own diabetes-related care. That's my second point on there. Self-motivation is key to optimal diabetes management. It involves more than just eating a certain way. This is kind of what Kelsey was saying with the medications. Diabetes involves attending medical appointments, following through on lab draws, blood work, taking the diabetes medications as prescribed, self-monitoring blood glucose levels, practicing good oral care or good foot care, coming to annual eye exams, storing the medications properly, etc. By kind of during your appointment verbally listing or saying each of these items, your client will probably be able to identify something that they are doing versus something they're not doing. And this helps to build their own confidence, which then sets the tone for discussion around diet. Once they feel that they are doing something positive towards diabetes care, they're more open to providing more information and open to learning more about what they can do about their nutritional care. At this point, I'll typically ask them about their current living situation, and the last point there is to provide reassurance that whatever their living situation is, we can work with it. So I know the title of these next slides, they just say methods to decrease carbohydrate intake. And again, as Christina said at the beginning, there's a lot of different nutritional priorities that they could have. And if I had my choice, my title of the slide would be methods to decrease intake of highly refined carbohydrates, trans fats, sodium, and added sugars while increasing unsaturated fat and nutrient-dense foods. But obviously all that doesn't fit, so unfortunately I've just had to identify decreasing carbohydrates on these slides. but keep in mind that the general suggestions I'm giving here involve moving away from highly processed foods and more toward minimally processed foods. And also, a lot of these suggestions flow together, so find what you feel is most appropriate for your client's living situation. So the first one I'm starting with is for shelter-served meals or temporary housing. I would recommend going easy on sugary sweetened beverages. Examples of sugary sweetened beverages are juice, punch, lemonade, tropical drinks, soda, chocolate milk. These are typically served with the meals and the snacks. Sandwiches are usually a pretty good controlled carbohydrate serving versus a pasta, a mac and cheese, or casserole. And a fresh fruit is always a great option if it's available. If they're getting their meals from a spiritual center, such as a church or temple, soups and stews are typically a smart option since they're balanced in carbohydrates, protein, and vegetable, and leaving the desserts or high carbohydrate rolls or breads to the side, like pastries, cookies, cake. And I've even in some cases had clients tell me that they're starving without the carb or the main like the bread side, so I'll let them know to take a double portion or ask for a double scoop of the meat just to have a little bit more satiety and decrease the risk of overeating on their carbohydrates. Places with these, I've found that a lot of them have either a pre-planned menu or some other kind of a diet plan, and so I might have a client sit with me in the office and we'll call the facility to ask to hear the meal options of the day, or if they're at more stable housing, I might ask the client to bring a copy of the menu and we can review it together. And if they have a phone, they can always take a picture of the menu or a picture of the meals, and that's another method we could use. If they're utilizing more shelf-stable foods or food banks, food pantries for their meals, there's definitely smart choices here too. These are good foods for people who may be living on the street or in a car or RV or in general just have little or no means of cooking. Choosing fish like tuna or salmon packed in water or in pouches are a smart, heart-healthy protein choice. Peanut butter goes more in that category too. Canned green beans, carrots, mushrooms, asparagus are more accessible, low-carbohydrate vegetable options. Again, low-sodium soups or stews are generally balanced in all the macronutrients. And fruit packed in water, the cans or the plastic cocktail-style cups, applesauce, sugar-free jello, sugar-free pudding. These are all good examples of carbohydrate-controlled desserts. If they're relying more on fast food, that's okay too. Again, the goal here is to work with whatever situation they have. For these kinds of places, I would recommend choosing an egg-based sandwich or burrito or grilled meat versus a heavily breaded chicken, fish, or other high-sodium meat patty. For example, Chick-fil-A has grilled chicken nuggets instead of the regular crispy breaded chicken nuggets. I would encourage them to avoid the combo meals since the combo comes with the entree plus a highly refined carbohydrate side like fries or onion rings and a sugary sweetened beverage, typically a soda. Rather, they can choose a diet soda or diet lemonade and look for a vegetable-based side. A lot of them say, no way, I'm not eating salad. Thankfully, there's more than just salad now. For example, KFC and Popeye's Chicken have green beans and coleslaw. And that bottom picture in the corner there, that's from the KFC website. It's their grilled chicken. I think it comes in a bucket, grilled chicken bucket with a side of green beans. The top picture is, again, from McDonald's website. It's their grilled chicken sandwich. And then the bottom left corner is the Dunkin' Donuts veggie, egg white, and cheese breakfast sandwich. Oh yeah, and another important point of this is if they're in your office and you're able to get on the internet, sometimes I'll go through the website of whichever restaurant they go to, just to see what options they have, and then they can kind of browse or peruse the options and see what they would prefer. So then my last slide is talking more about convenience stores and gas stations. This one is more common. We also have a substance use disorder program combined with our homelessness clinic here. And a lot of these clients utilize either gas stations or convenience stores or 99-cent stores as their main source of food. So again, here there are a lot of maybe not so great for diabetes food options, but there's some good ones too. So rather than going for the candy, snack cake, donuts, pastries, I would encourage them to just check out some of the other aisles and the refrigerated section. Any kind of low sodium or unsalted nut is a heart-healthy choice, and low in carbohydrates. Peanuts, cashews, almonds, pistachios, walnuts, pecans, etc. Seeds are high in fiber and unsaturated fats. Like in the picture, you can see the unsalted flower seeds or pumpkin seeds. Both of these are often combined into a trail mix, and even if the trail mix has some candy or raisins or other kind of sweet addition to it, it's still a relatively carbohydrate controlled serving as compared to a honey bun or a donut or some other highly refined carbohydrate snack. Same idea as jerky. I put jerky up there. Yes, it is high in sodium, but it is at least a good source of protein, and it would have more nutrition than another high sodium snack like pretzels or chips or taquitos or something like that. Air popped popcorn is another good kind of more filling option. And then over in the refrigeration section, depending on the location or the store, I've seen a very wide variety of options. Smart choices might be string cheese or cheese cubes, chicken salad, tuna or egg salad sandwiches. The picture there is hard-boiled eggs, and those are available through SNAP, or even travel containers of carrots and ranch or broccoli and hummus. That's it for me.
Thanks, Kimaya. Hi, my name is Elizabeth. I'm a dietitian at Heartland Alliance Health in Chicago. I work with a few different programs within Heartland, including our refugee health program, residential housing facilities, food pantries, and one of our federally qualified health centers. I share that to say if you think adding a full-time dietitian to staff seems like a big ask, see if there are other programs who could benefit from dietitian services. But today I'll mostly focus on my work with our FQHC. Stepping back a little, this image is from the Blueprint for Complex Care, which is available free online as a PDF. It was really exciting for me to see food access and nutrition as part of the complex care ecosystem, and I think it's important to recognize the role nutrition plays in health in the context of other social determinants of health. And then taking it down to the individual level, as all of the dietitians before me have said, it's important to form a relationship with the patients we serve, and that relationship often starts with their diabetes diagnosis. So helping patients understand what their diagnosis is, what blood sugar is, why food is an important piece of diabetes management are all ways to begin forming that relationship and having that conversation with our patients. And one resource that I like to use to describe basics of blood sugar and human metabolism is kidshealth.org. They have a few videos and worksheets explaining basics, not just of diabetes, but other health needs as well. And I like using it because it can be for different levels of health literacy as well. And that is an important piece of all healthcare and nutrition. There's so much confusion and misinformation about nutrition that communicating accurate information effectively is an important part of nutrition education. I pulled up an example of identifying foods as go, slow, or whoa foods, and it's designed for middle schoolers, but I have definitely used this in practice doing individual nutrition counseling with our patients. I included this slide because another piece of nutrition, especially in diabetes, MNT, is a lot of fear and anxiety around food, which Kimaya just mentioned. And I always try to frame food as something positive, focusing on foods to include as opposed to foods to exclude. And since there is so much uncertainty around a diabetes diagnosis, especially among those experiencing homelessness, making it something a little bit less scary and something more manageable where they actually do have options in their care. So I do individual nutrition counseling, and then I also work with different groups. And part of working with groups is incorporating nutrition into groups that already exist or programs that already exist in the clinic. So whether that's starting a garden, even something really small, a cooking group, or a walking or exercise group. If more information is needed about cooking groups, there's a free curriculum from Cooking Matters at the food pantry that's available as a PDF online. And then the NIH has some free resources online related specifically to physical activity for healthy aging. So my last slide is about community partners, which all the other dietitians have also talked about collaboration with community partners and referral of nutrition care. I agree with them 100%. One thing I have to add related specifically to working with community partners is working with different colleges and universities to incorporate community health in their experiential learning. So I was able to partner with nursing students and a dietetic intern to table at a health fair at a nearby shelter, and we had a lot of fun partnering together and then also helping them to learn about the needs of our specific population of people experiencing homelessness who have diabetes. Thank you for listening. I'm going to pass it over to Laura.
Thank you, Elizabeth. Hi, everyone. I'm Laura Samnata, the Director of Nutrition Services at Open Hand Atlanta. And when we started this project, I was working with Elizabeth at Heartland in Chicago. But in December, I made a professional move to Atlanta. So I will be able to give you perspectives on food and nutrition interventions from both locations. First, I'll talk about my projects in Chicago, and then what we're currently doing here in Atlanta. So in 2017, I had a lot of staff come to me at our FQHC where Elizabeth works. It's also a patient-centered medical home. And a lot of staff were telling me about food insecurity happening in the clinic, a lot of hunger. There's a lot of hangry visitors in our waiting room, and the staff had a lot of concerns about those folks living with diabetes and, waiting maybe an hour or two for their appointments and what their blood sugars were doing while waiting. So we decided to form a team. We established the anti-hunger team. It was comprised of staff at all levels of the health center. We determined first that we would organize donations to help us sort of get food. There wasn't money available to help us purchase food, so we sort of organized the team to help us gain donations. So we asked for peanut butter and jelly and bread, and staff members volunteered to make peanut butter sandwiches. We also mobilized our board and other community members through social media and Amazon wish lists, where we loaded dental-friendly and healthy granola bars, dried fruit, and other easy-to-eat items, ready-to-eat items, so that we could hand those out in our clinics and in baskets in the waiting room. Eventually, we were also able to find a small budget to purchase bananas and oranges, and we set those out in baskets in the check-in and check-out area. Then we also introduced the Hunger Vital Sign, the two-question food insecurity screening. The MAs at Heartland Alliance Health asked that question. And if someone screened positive, we provided info to soup kitchens and food pantries in the area that they lived and had access to. And then it also triggered a referral to our dietitian, Elizabeth. And we, told our team and at the health center that we really wanted to prioritize diabetes. And then we also utilized other resources in the community. Once our neighbors started hearing that we were asking for food donations, they started donating food from the restaurants. And it was very exciting to see this sort of community effort to help us. Next slide. So another part of Heartland Alliance Health in Chicago is a Ryan White-funded network of food pantries called Vital Bridges. And this food pantry, as well as Open Hand Atlanta, where I am now, is a part of the Food is Medicine Coalition. And it's a nationwide coalition of food and nutrition organizations that started in the epidemic of HIV and AIDS in the 80s. And all of these organizations serve medically tailored meals in combination with medical nutrition therapy provided by dietitians. And we are advocates that believe that food should be a part of healthcare. So at in my last year in Chicago at Vital Bridges, we we changed our food pantry to be a medically tailored model. Our grocery menus it's a client choice, and it's based on the My Plate, and it's and for clients to be a part of the medically tailored menus, they have to see a dietitian beforehand so that they can explain it and make sure that the client understands the different menu. So we sort of tailored our pantry foods to be available by the chronic disease that they might be dealing with. So we have a regular healthy menu that everyone can be on. If they wanted to be on a diabetes friendly, a heart healthy, renal friendly, or vegetarian vegan menu, it was a referral to the dietitian so that they could explain it first, like I said. And then we also developed a non-perishable menu for unstably housed folks. These menus provided more fresh fruits and vegetables if you're on the medically tailored version, and whole grains. We did include quinoa and brown rice and other 100% whole wheat bread as well. And then we decreased amounts of the high-fat, high-sodium foods that were available in our food pantry. So we no longer are serving hot dogs or bologna. And this falls in line with the nutrition policy that this food pantry wrote. It outlined the foods that we wanted to emphasize in our food pantry to help support our clients' health. And we sort of limited or told people we were no longer accepting things like hot dogs and bologna and other, pastries, cakes, and cookies. If you'd like to see a copy of the grocery menus, I'm happy to send along with Elizabeth's permission. And so now I'll talk about my work in Open Hand Atlanta. So we are a medically tailored prepared meal delivery provider. So our meals are medically and nutrient balanced, designed by a team of dietitians. And we serve over 5,000 meals a day with the help of over 13,000 volunteers a year. Our meal plans include a healthy balance. They're all low sodium and diabetes friendly. We also have a renal menu, mechanical soft menu for those with dental issues or receiving treatments that affect their chewing or swallowing or digestive system. We have a vegetarian menu. And we also serve non-perishable boxes and emergency boxes to community partners across Atlanta. All meals are low sodium and they're made with healthy fats. To be placed on these meal plans, they have to be referred by a provider and having one or more chronic conditions and meet the income requirements. Our team of dietitians also provide cooking matters classes, medical nutrition therapy, and fruit and vegetable prescription program. So lastly, I wanted to bring up that RDs can bill for services as a source of revenue. I think there's a lot of dietitians on the line already who probably already know this information already, but if you don't, if you have more questions about billing for medical nutrition therapy or diabetes self-management training or the diabetes prevention program, I'm happy to answer your questions. There's a lot of resources online as well. So with that, I will turn it back over to Darlene. Thank you.
Great. Thank you, Laura. So for the next few minutes, we're going to just talk a little bit about our diabetes and nutrition and diabetes guide that we actually published, or we came together to give some strategies, and that was you heard from the authors today of this guide, and it's available down in the pod. You can download that resource, and also when we archive the webinar, there'll be other. We'll give the link to the council's the council's website where we've updated some more of our diabetes resources, and then we also are part of the National Cooperative Agreements Clearinghouse, and you will be able to find our resources there that will be available to everyone. So now we're opening it up for questions and answers, and I don't see any in the chat pod, but I did have a question for Christina. When you were talking, you were saying that you screen for social determinants of health. What instrument do you use to screen for SDOHs?
I would have to check with my quality manager because the care coordinators do that.
Okay.
But I can check with them and send it to you.
Okay, great. That would be helpful. Thank you so much. And Kelsey, I was very interested when you were talking about the different teams, and I think I heard you say that you have a veterinarian team that works. Can you explain a little more about that?
Yes, so we have a vet on the outreach staff who donates her time because a lot of our patients who are experiencing homelessness often have support animals. And so she'll go out to the camps and look at their animals and give them like vaccines, medications, make sure they have food, that kind of thing, because with limited income sometimes they're not able to get into your normal veterinary clinics to have those procedures done.
Great. Thank you so much. And I should mention in our guide, Kelsey was kind enough to give recipes for use of the grill. She mentioned in her presentation that they do a lot of food demonstrations using the grill, and she has shared some of the grill recipes, and they are available in the Nutrition and Diabetes Guide. We just received a question for receiving the medically tailored meals. There was some confusion regarding, is this all donated food, and can patients receive it free? So, Laura, can you talk a little bit more about the medically tailored meals and how that works?
Yes, both in Chicago and in Atlanta, it's free for patients who qualify. The food in Chicago is, we do have a budget to purchase food through Ryan White, so we're serving people who are living with HIV and AIDS, and and we also accept tons of food donations. The food here in Atlanta is all purchased through our budgets, our funding, and fundraising.
So do the patients, so is there a building where the patients come and pick their food, or is it delivered like Meals on Wheels?
Yeah, here in Atlanta, it is like a Meals on Wheels,
Okay.
but we definitely like to promote that we're better than that.
Right, okay, but they are delivered to the patient.
Yeah.
Okay,
yeah.
And in Chicago, is a pantry, do they go, so they have their diet in hand of what is their medically tailored diet in hand, and then they go to the pantry and hand it, and then they can select the food that matches their dietary need?
Right, with the assessment from the dietitian who can help them help them sort of determine the client choice grocery menu. Yeah.
Okay. There's a question here that says that their center, wait, let me get here. Our health center cannot afford to have a dietitian on staff. Do you think the nurse staff could help with this teaching? And if so, what would that role look like? Does anyone want to take that question regarding not being able to afford a dietitian on staff, and if a nurse could take that role? I'll start, and then other people can chime in. I know when even starting this project, I reached out to health centers trying to locate registered dietitians that were on staff, and many health centers do not have the dietitian on staff, but they refer. They have a referral system, so they have found a registered dietitian in their community where they can refer patients. So that can help to have, even if you can't afford a dietitian on staff, find one that is in your community that is available for referrals, and then or consultant that may come 2 or 3 days. But it's very important to have that background regarding nutrition. I think a nurse could possibly play a role, but then again, as far as having people really play to their strengths and interests, registered dietitians, their interest is nutritional health. Their interest is medical nutrition therapy. And so I don't know, unless the nurse is a certified diabetes educator or a health educator, they would possibly be able to fulfill that role. But I would think the first priority or the first resort would be trying to find a registered dietitian in your community for referral purposes. Does anyone else have any suggestions, perhaps, on the call?
Darlene.
This is Laura. Go ahead.
Go ahead.
Go next.
This is Christina. I just wanted to reiterate, the RN, maybe we're getting certification as a diabetes educator, or looking at places, if you can't find any dietitians to refer to, even looking at like your health department or your extension office for health education. Sometimes they just have good resources.
Right, great, thank you. And there was someone else that wanted to share?
Yeah, sorry, this is Laura. I just wanted to add, it also doesn't have to be a full-time position for the dietitian. You know, you could have a dietitian come in for 4 hours a week or 8 hours a week. I think there are a lot of dietitians that would be excited to work in the community in that way too. A lot of dietitians sort of divide their time, you know, between a health center or a couple health centers or another part-time gig. So don't think you have to support a 40-hour. There are positions where you could absolutely ask dietitians to work part-time.
Right. And I know when I was in school as a registered dietitian, we did rotations through different sites. And so when I did my rotation in the community to provide community nutrition, that was also an option for us. We kind of chose different clinics. We chose different facilities that we provided services as part of our rotation as well as our community service. And so that may be another option, just partnering if you have a university or a school that has an allied health and has registered dietitian or dietetic school. You may be able to work with them as well, seeing if some of the students who are training can be part of that, could be part of your organization. Okay, I'm trying to see if there's any more questions. We have about 2 minutes. Is there anything that anyone wants to have with closing thoughts before we close out? And I'm going to just kind of reiterate some of the steps. But were there any parting suggestions from our faculty?
Hi, it's Kimaya. I did just want to answer that one question, how supportive are your physicians in prioritizing dietitian therapy? From my experience here at the VA, it's more, I wouldn't say anyone is opposed to it. I think a lot of times physicians or primary care providers just don't know exactly what we do or how we could really help. So for any dietitians on the line, just maybe I did a presentation, an in-service, a 10-minute in-service on what I do and how I can help with diabetes management. And after that, I am happily drowning in consults from them. So whichever physician or primary care provider you're working with, a very brief 5 to 10 minute or even 2-minute discussion may be a really good entry point. And for people who are working more as contract dietitians, same kind of principle for getting referrals.
Great. Thank you, Kimaya. Appreciate that. If there's no more questions, we have reached our time, and so we want to thank you for joining our Nutrition and Diabetes webinar that has been produced by the National Healthcare for the Homeless Council. This webinar, as I mentioned before, will be archived on our website at nhchc.org within 3 business days, and a link of the webinar will also be emailed to the registrants along with all the resources. At the close of this webinar, there will be an online survey. Please complete the survey. That helps us to improve on our presentations and also know where the interest lies. So please complete the survey at the end of this webinar. And also visit our website, as I mentioned, for additional information. I want to also invite you to our workshop. We are doing a workshop at our National Healthcare for the Homeless Council, National Healthcare for the Homeless Conference and Policy Symposium on May 24th, and you will hear from some of the same staff or faculty that have been on this webinar. So please join us, and there's a link to register for the conference.